Good afternoon and welcome to Ashgrove TV. This is our monthly TV show for you to answer your questions about your injuries and to help you understand what your injuries are, as well as provide you with top tips and information about how to look after yourself. So today I have with me Sheridan, who is our sports rehabilitation expert. So he treats many athletes, and also works as a strength and conditioning coach. And his big thing is doing biomechanics assessment, so looking at how you move and how your movements are causing your injuries or preventing you from recovering from your injuries. Jay, welcome to the show.
Thank you for having me.
So, we're going to talk about the knee today.
Yeah.
Stephen and I have discussed in quite a lot of detail the knee anatomy,
yes,
and also a lot of the different types of injuries. So what are we going to do today? What are you going to help us with that's different?
Well, what I want to bring to the table today is you've looked at the diagnosis and the injury, how somebody like me comes along and begins to fix that injury, essentially, through both treatment and rehabilitation, what we now call prescriptive exercise. So it is taken daily, like a pharmaceutical drug could be. I always think it's a bit pretentious, prescriptive exercise, but I think it does sum up the need of consistency with rehabilitating injuries, particularly knees, where we know that if the right rehabilitation isn't implemented, that person is really going to struggle to get back to their sport massively. And if they do, they will not be at the same level that they were pre-injury. And actually later on in life, we may start to see osteoarthritis.
So this is one of the things that you and I really wanted to cover, isn't it?
Yeah.
What exercises not to do, and why not to do them.
Yes.
Because I think the number of knee injuries we see in the clinic is probably just slightly lower than the number of back injuries, isn't it?
Yes.
There's a huge number of patients come to us with knee problems.
Yeah.
And often, in my experience, they've been given exercises to do that are either useless or damaging.
Yeah.
And I think, and it might be that they've just found them on the internet, haven't they? They've looked up knee injury exercises and come up with something that isn't related to their...
Most definitely, because YouTube and things like that, people put in something into YouTube, I need my knee rehabbing, and they may have completely the wrong exercises. Those exercises may have actually been put up there by somebody who's not really a professional in such things as well. There's a danger of that. The other danger I see, to pick up on a point with you about the right exercises, often practitioners, therapists will give such what I call conservative exercises that are too easy for the patient, for their injury.
Well, that's something I really hadn't expected you to say that today. I hadn't expected that to come up at all. I always think that we're giving too much of it in the way of exercises, but you tell me it's not true.
The golden rule of exercises, right, without treading on, going to get controversial, NHS toes, when patients come to me and they've had input from an NHS physio, largely with knee protocols, they could be like 4 sheets of A4 paper, which can be sometimes 20 exercises. We know, research tells us, you don't want to be giving a patient any more than 5 exercises.
Yeah. There is actually research to say that, isn't there?
Without a doubt, because we seem to think actually only a certain percentage of people actually carry out their rehabilitation properly anyway. The other issue I have with paper, the stickman diagram, the written, that most people learn visually. So at Ashgrove Clinic we use Rehab My Patient, right? Which is fantastic software that's both video based, you can watch the movement, study the movement, and there's audio too. So you're covering all the bases of learning for somebody too. And it's progressive. And whereas I think these protocols are given to somebody for say 6 weeks before they get a new protocol. Well, we know we need to be changing a protocol most of the time, certainly within 2 weeks.
Okay, so let's move on to different types of exercises.
Yeah.
What we're going to talk about today is exercises for certain conditions, certain injuries, but very briefly take us through those long, complicated words that we will be told by physiotherapists or sports therapists like yourself. What do they mean? The what's it?
Right, plyometrics would be anything. It's been called ballistics too, and people might know that. Some of the viewers might know it more as ballistics. Anything that's jumping.
Okay.
Okay, so something with an osteoarthritic knee. In fact, with most knee injuries, we remove plyometric jumping. So if you're a rugby player, a footballer, obviously a gymnast or dancer, something where you do a lot of that stuff, that can be bad news initially, because that is a big part of your strength and conditioning protocol when you're fit. But when you have a knee injury, we call it regression. We have to step back from it and we exchange that exercise for something that's safer.
Okay.
Okay.
Tell me about other types of exercises. We've got plyometrics.
Yes.
Give me one of the other weird words that you guys use.
We've got closed and open chain.
Give me a demo.
I'm going to demonstrate.
Closed and open chain.
A closed chain is when we think about it, forget the words, just think a squat, okay? So a squat is closed because I'm not moving. We call these levers. I am not moving a lever. If I was a lunge, I'm moving a lever. That is open chain and more risky.
Why is it more risky?
Because the control will not be there as much, particularly with a knee. If somebody's got an ACL injury there, they may find that they wobble, whereas here, we can kind of fix them. We can put them against a wall, so they've got the sensory feedback that they're safe. There's a wall there. We can reduce the squat to a quarter squat, half squat, closed, not so much pressure on a knee, and start to move it where they may not have the full control within the knee joint at that time.
So one of the types of patients that we see a huge amount in the clinic is osteoarthritis in the knee. Basically, a patient will come in and say, it's my age, isn't it? There's nothing I can do.
Yes.
Current thinking is that they need to do exercises.
Yes.
What exercises?
Squat that just demonstrated, believe it or not.
How far? Show me a squat.
It's really, right, okay, this is where it becomes complex, because if it is moderate osteoarthritis, they're going to be full squatting, for me, personally. That's therapeutic risk I take as a therapist, because I've seen it work with my patients. If it's more severe in nature, we're still going to squat. We may ask them to be in a higher chair or to put pillars, so they've got the feedback, their bum hits that. So they're not in any space of time going to go too low and injure the knee. So somebody with a severe OA, they're going to be on a higher chair, they're going to have their bum in contact with something, so they know they've reached the end point of that movement, know it's to come up again.
So you're basically getting them to do a squat onto a chair, so that they can't go too low and they can't hurt themselves. What's your aim in that? What are you trying to achieve with the squat?
To keep movement within the joint, because one of the things we tend to find, people want to immobilise that area and not use it too much when they're injured, which is nonsense. It's the opposite. We need to move it, but it needs to be moved in a safe way. So we're looking to keep strength within the 3 leg groups, if you like, the quads, the hamstrings and the calves, but also the glutes, so the muscles of your bum, okay? With this, we can progress it. We can start to get them a little rucksack with a bit of weight in, so they can start to bring more of a strength component into it as well, which will keep strength within the joints. Because if we're strong here and here, we will protect our knees.
A patient coming into me with arthritis of the knee is likely to say to me, that's going to hurt. Doing a squat is going to be painful.
Yeah.
Where do we start with somebody who is frightened of doing the exercise, is very aware that they're going to have pain to start with? What do we start with?
Right, I'm aware you've got a little bit of back injury, so I want to be careful with you. But if you would stand with me, if we could, what we do, I will build up the chair with some pillars and things we have within the clinic treatment room, and I will come round with you.
We're going to dance
We're going
on
to
telly.
dance, yeah, we're going to do some of this and we're going to do some of that. And I will say, I have got you. Have a little look behind at your chair, see that that is supported, and we're going to go down together and we're going to squat together. And stop, you feel the pillars, and up we go. And we're going to do a few more of those to get them used to the fact that they are safe to do it. If they are in pain, then we have to rethink about whether we give them a squat or not. But it is to give that patient the confidence to know they can do these things, because everything in their brain or another medical professional or somebody online would have told them they shouldn't be doing that, but they can do that.
Okay, so moving on to ACL injuries.
Yeah.
Where would you start with rehab? Now, I know we've already discussed that surgery these days often isn't carried out, and we've talked before about Ruth, our osteopath Ruth's ACL injury.
Yes, yeah.
But where would you start with the rehabilitation?
So is this if they've had reconstruction or
no reconstruction?
So no reconstruction. Okay, one of the main things to do is definitely everything is closed chain initially, where they can't move that leg too much. You see people in gyms doing what we call leg extensions, so they've got the bar there and they're doing this and they're working the quads. Terrible movement for an ACL injury, that is.
Why?
Because what we're doing is we are putting so much stress on the ACL area, and if there's a meniscus issue with it, which is the cartilage of your knee, that is also putting pressure within the meniscus, and they're probably not going to be as in control of this movement as what they think they are as well. So a lot of the time, I like resistance bands, which I think a lot of people use now. Loops that we can loop round, we could squat, we can work on the gluteals for the knee. So I'll just demonstrate good exercise for them. We can get you coming outwards with the hip, because we need to fix the glutes here.
You might need to do that face on, so that...
So we need to just protect the knee here, so we can get people standing, we can get them laying, and they're starting to work the glutes to protect the knee. It is not as simple as just working the quads, which for so many years everybody just, you better work on your quadriceps, these muscles here to protect your knee. Not true. These calves, glutes, so much more important actually than just working quadriceps. So
that was something I was going to ask you. Certainly when the 3 times I've injured my leg, each time I've been given exercises for a particular muscle, the inside quadriceps muscle, and the exercise I was given was usually to put cans of beans into a sock. Either end of the sock, tie it a knot in one end, and then drape it over my ankle, and then do lifting like that. And preferably, they said to externally rotate it, turn it outwards, and then to lift my leg like that.
I mean,
what's the current thinking?
It's such an old school exercise, that, and I remember using that, and we did use, but of course we know now if we're laterally coming out, yes, we will hit that most, what we call internal, inside of the 4 muscles of the quadricep group here, the VMO, but with that comes more stress onto the knee, and actually potential stress onto the hip joint as well. So current thinking with VMO is to just change the squat position. So if I could just show you, we know that we're going to hit. So you think about sumo, all of this. We have something called a sumo squat. So we're wider, wider stance. Typical squat, toe slightly out, okay? No, we're going to come out a little bit, toe slightly out again. I'm going to come down, we're going to activate that VMO there. And it's a safer way of doing it. I mean, one of the classic things used to be putting somebody on an incline on a treadmill and getting them to walk backwards or upstairs backwards, because that also activates VMO. But increasingly, strength conditioning's changed a lot. Instead of us isolating muscles so much, we know that if we work with the group of muscles, they tend to have something. This is the only geeky bit. It's called a cross-education, okay? They will want to imitate the stronger ones, and thus they will become stronger rather than just isolating the muscle now. So we don't tend to do that so much.
Are you just giving muscles personalities?
Yes, they've all got their little personalities, haven't they? But no, they will learn off one another, and it sounds geeky, but the evidence is all there for it. The only time that, of course, is different is with the guys and the ladies that are competitive bodybuilders. They will focus solely on individual muscles, but for rehab, we don't go down that route anymore of trying to get the VMO. We know that if we're changing your squat position and doing different things, that will activate, and it will want to activate as strongly as the others.
So if you have an ACL injury, that sort of sumo squat Would that be okay to do at the beginning of the injury, shortly after, or would you need to wait? How do you build up a protocol?
It's interesting with a squat with an ACL, because actually it shouldn't really stress the ACL too much if we reduce the squat depth of it, and certainly no weight. We wouldn't have, barbell or any weight on us. What we could also do with an ACL, I'll demonstrate here. There's a machine called a leg press. So if you can imagine, I'm sat in a seat and there's a plate, big heavy metal plate here, and it's a pin weight device. My feet go up and I push, and we reduce that movement, but it is a safer movement again for the patient possibly than a squat, because we can put the weight so low on that they're safe. Whereas if I'm dealing with, like, as I have done many times in my life with rugby players, and I've got them doing a full weighted body squat and they're this size, there's a lot of stress going through on that knee. Whereas,
bearing in mind the majority of the people who see us, plenty of people who see you go to the gym regularly. A lot of my patients less so.
Yes.
So if they're not going to the gym and they're not able to use a machine with a plate on it, would you start with gentle sumo squats, or would there be a different starting point for you?
With somebody at home that's nursing an ACL, I'd probably use, again, technical term, isometric exercise, but forget the terminology. Purely what it is would be me, say, pushing against something I can't move. Okay, I can't move no matter how much force I put on that, but I'm still working my muscles.
So how would you do that for your...
Against a wall, this is going to be difficult to demonstrate. I don't know whether they're going to see me if I lay down, but I would get the patient to lay against a wall. But if they can see my feet, though. No, they're not going to see my feet.
So.
Okay.
You have to pretend you're sitting on the wall.
So what we do is we're laying down and we're pushing against a wall or a door that's shut. We cannot move it, but we are still working our muscle groups. It's very safe.
That's nice and simple.
It's like
very easy to do at home.
Isometrics are, and they probably are the first stage of rehab if we've got a full ACL tear, because we don't want that joint moving too much at that time. Okay. And it may well be in a brace that doesn't allow it to move, but we can still work the muscles around it.
Okay. Tell me about, what are the other common knee injuries that you see?
Well, a lot with the kneecap, what we call the patella. The kneecap, particularly in runners, will want to move a little bit, which we call maltracking. And tracking is like the car, just pulls to one side, tends to pull outwards. Often down to tight muscles on the front of the leg, tight muscles within the side of your bottom. And ironically, sometimes can be the opposite. People are not strong enough on these, so it moves around too much. There's two ways of doing that, but it can create a lot of what we call tendon problems, okay? So underneath the kneecap, above the kneecap, it can cause instability, which causes swelling, which means the patient has to stop doing what they enjoy doing.
And your assessment of that and your approach to rehabilitation, I'm going to guess, will depend on what the cause is.
Yes, yeah.
And the plan is then, I guess what I'm getting to here is that if somebody has got a kneecap that's not staying straight and is tugging to one side or the other and then is giving pain above or below, if you then look on YouTube for exercises to do, this is one of the times when you could actually be doing you need to push it in, push the socket
It's come out a little bit, has it? Yeah.
So this will be one of the occasions where it's important to know which exercises to do, because if you're too tight on the muscles at the side or in the glutes, then tightening those is not going to have a good effect.
Such a good point. And I see time and time again, therapists will give exercise without actually assessing how much movement is in the joint, has it got enough movement, assessing how tight or short those muscles are. And that's, of course, where treatment would come in, because we'd want to loosen those structures if they're tight. And then the patient can also help us with that, either by stretching. I prefer foam rolling, these devices that we can roll on, and they will relax some of the tension within the tissues, and then the exercise protocol would probably start from there. So it would be slightly different. They may not get exercises straight away. We've got to loosen this off and I've got to work on you first, then your exercises, because otherwise we're giving exercise to somebody who's already damaged. They will become more damaged. So it's knowing when to implement that. Yes.
It's interesting, nothing to do with knees, but I've seen that a lot with the pelvic floor, that people have done pelvic floor exercises either for incontinence or other issues to try and get more stable, or core exercises. Yeah. And you end up, actually, you can see that the pelvic floor has become over-strengthened, which is causing other problems. I think understanding when the muscles are too tight and when they're too weak is really complicated, isn't it? It's really difficult to know. It really
is difficult. I mean, and that's why you're always going to check both sides. You know, if somebody comes in with a left knee, I'm still going to have a look at the right knee, the so-called healthy one. Is that healthy? Is that developing issues? Or it gives me a marker because we're always going to see imbalance in our people, whether they're more of an osteopathic, patient, or whether they're more of my sort of patient. We're going to see imbalances, and a big thing, and this ties in nicely to knees, because a lot of knee issues do develop from imbalances. One side a little stronger than the other side's trying to catch up, or a joint, and it could be the hip joint above the knee or the ankle joint below, which is a little stiff and not so much movement in that, which means there's more pressure going through that knee.
Which means you're building up the muscles in an imbalanced way on that side, which could then lead to other problems.
And again, with that is why I would look at doing single leg work with a patient. So we can do single leg squats, because then we're going to get more balance than just doing two, like a two-footed squat, a typical squat, is massively useful. But as I'm starting to progress that person back to their sport, they're going to start doing more single leg things, because their balance is going to have to improve, their strength will improve. And if they've got a weaker side, going back to cross-education effect, it will want to copy the stronger side, which we know is central nervous system. We want it to emulate that. It's really freaky and geeky, but it's definitely valid. It definitely works. I've seen it. It's developed from neurological patients from many years ago, where they found that just working on the left side of a stroke patient, and they occur on the right, but just working on one side wasn't enough. When they started working on the healthy side, the left side got better, quicker, got more movement back, I should say. Yeah.
Our brains are complex things, aren't they?
Yes, indeed they are. Yeah.
Now, I have had a question in about Baker's cysts, and slightly, I'll allow us to go off topic slightly with exercises. Just give us a little bit of information about Baker's cysts, and can they be helped, or do they need surgery?
Oh, that's a really good question. Right, with the Baker's cyst, I see a lot of them, and there's normally a component of an injury to the meniscus, the cartilage of the knee, which could potentially mean an osteoarthritic knee. So, yes, treatment-wise, we use our fantastic laser machine we've got at the clinic, because hands on there is just going to upset the area. And you will normally see that swelling with a Baker's cyst. It's normally prevalent. It's normally tended to touch.
We ought to actually just say what a Baker's cyst is, isn't it? It's a swelling at the back of the knee.
So this is the front of the knee. You see the kneecap. And it's going to be in what we call the crease of the knee here, okay? And it's not above and it's not below, it's going to be right into that crease. The patient is normally in pain with them, and you can normally visibly see it. It's a tricky one for exercise, so we go back to squat mechanism would not be appropriate.
Because you'd be squashing the cyst.
You're compressing this thing, you're compressing this cyst. In severe, cases, sometimes they do need to be drained, aspirated, whatever you want to call it. If they rupture, that's not very good, because actually the patient's in an enormous amount of pain, and the recovery of that tends to be slow. So that's why exercise-wise, that may be one where they would be definitely going back to our isometric. I won't go on the floor again, I could hardly get up last time. We'll go back to the isometric exercise where we push and we don't move that joint. That joint's going to stay fixed, because I still wanted to keep some strength.
That's interesting. Again, it's coming back to the strength of the muscles,
Yeah.
not just the range of movement that the joint has.
Yes, exactly.
Okay.
I mean, we do want the range of movement exercises ideally, but initially we can't put that joint through too much stress if it's already damaged. It would be nonsensical.
Okay. So we've talked a lot about actually working the quads.
Yeah.
What about the glutes? Everybody knows we have to have strong glutes.
Yeah.
Do you have favourite exercises, bearing in mind what you said earlier on about the effect of weak glutes or over tight glutes and their effect on knee mechanics?
Yes.
Do you have favourite glute exercises?
Yeah, I do most definitely. I find, would you like me to show you some that I like, or do you want me to talk about quickly?
If they're lying down.
They're standing, they're not lying, don't worry. So obviously we talked about lunge. Lunge is fantastic for glutes. So we could go head on, okay? So we could do a forward lunge. We could do then backward lunge. Okay, fantastic for glutes, but we are hitting the glute maximus. We need, so this is the big muscle, isn't it? The max. We need to hit another couple of muscles or so on the outside, and we can only do that by coming outwards like so. And I could be laying on the floor doing that. We could be doing fire hydrants with bands where we're coming out like so. It's called the fire hydrants, yeah. And we come out like so, and you will really feel those. All my patients that have never done those before feel those ones more than anything. And it just goes to show how they don't do anything coming out to the side. Everything's this with my patients, if we're not careful. Squatting, loads of deadlifts, everything like this, nothing coming out.
And that's the same, I would say, for a lot of our patients.
Yeah.
So mine are more likely to be gardeners, dog walkers and horse riders. And for all three of those, we don't do anything where we put our legs out to the side. My sister, who's a dancer, total opposite.
Oh, of course.
Lots of leg out to the side.
Yes, yeah.
But for the rest of us, we don't do it much, do we?
It's such an important thing to do, because if you're only working in one, all movement in life goes through three kind of, we'll call planes, doesn't it? We've got different planes of motion movement. Life is not just walking forwards and backwards. And when people, so we know a lot of injuries in rugby and football happen when people are taken out of that straight line and they're put to the side because they can't take the force of that. Okay, so it's massively important to train the outside of your glutes. It's hugely important. And again, this ties in beautifully to knees, because we know a lot of ACL injuries actually happen because of a lack of strength in the glutes. It starts at the glutes. It all starts at the glutes. Well, they're in the middle, aren't they? They're supporting this, you know. So it's criminal not to work on the glutes, actually.
I love that. Criminal not to work on the glutes.
I won't have it. I won't have it, Claire.
If you take nothing else away from this,
it's criminal.
Bear in mind, it's criminal not to work on the glutes. So I'm going to add one small thing to that, which is, if you're not going to the gym, if you're not training regularly, one of which currently I don't, one of the things that I do is if I'm on the telephone or if I'm thinking, I walk around a lot, and I often do little pirouettes, or I do one step out to the side, one step out to the side. I try and make sure that while I'm walking around and processing things, I'm doing it with my legs moving in different directions.
Fantastic.
And I think that's all we've got time for today. Thank you so much for joining us. I hope you found that useful. I hope you found it interesting, and also that you can incorporate some of this into your normal life. We're doing this so that we can answer your questions and we can help you feel better. And I'm hoping that that's the effect that today's going to have. Enjoy the rest of your afternoon, and goodbye for now.